The views and opinions expressed by the following program and its participants are solely their current opinions and do not reflect the opinions of Bobo 89.1 FM and DMS Broadcasting respective stations. The program participants' opinions are based upon information they consider reliable and based on their knowledge.
The Cayman Islands Health Services Authority's general practice and public health clinics have relocated to Smith Road Medical Center. At the new location, you'll receive top quality care in a comfortable, modern space, enhancing your patient experience. Do you have flu-like symptoms or other non-emergent illnesses or injury? HSA's new urgent care walk-in clinic is now open at the main hospital campus. The new general practice location is for appointments only. For more information, call 949-8600 or visit HSA.ky.
HSA's cardiology clinic is now located at Smith Road Medical Center. Our cardiology team provides expert care and treatment for heart conditions such as coronary artery disease, heart failure, arrhythmias, hypertension, congenital heart diseases, among others. The new location offers state-of-the-art cardiac diagnostic testing, including echocardiograms, ECGs, and stress tests. To contact, call 949-8600. At HSA, your heart matters to us.
The Health Services Authority's new pharmacy is now open at the Smith Road Medical Center. The new location features a large, comfortable waiting area and ticketing system to improve the patient experience. All uncollected prescriptions and refill requests previously submitted will now be available for collection at the Smith Road Pharmacy. Request your refills online at hsa.ky via WhatsApp 925-6534 or call 244-2715. For more information about our pharmacy hours, visit hsa.ky.
At the Health Services Authority, we want to keep you informed about the latest developments that impact your health because your health matters to us. Join us each Friday and Saturday from 1 to 2 p.m. as we cover health news, offer advice, and answer your questions on Healthcare Today with HSA.
Welcome to another episode of Healthcare Today with the HSA. I'm your host, Chuck Taylor, and this is Bobo 89.1 FM. Each and every Friday and Saturday, we get together and we talk about all things health-related, in particular your health, because we want to keep Cayman. You got to be healthy. You know, health is wealth, as they say. And with me today, I have a Dr. Carl Brown. Good afternoon to you, sir.
Good afternoon. Thank you for having me.
So, in your field, you are considered an anesthesiologist. Am I correct in saying that?
That's correct.
Okay. So, but what does that entail? Just for my listening public. So I assume, people have an idea, but give me the real details about it.
Sure. So the responsibilities or the roles of an anesthesiologist are multiple, but they all fall under the umbrella of ensuring that patients have the minimal amount of pain. So in the preoperative period, usually before surgery, this involves ensuring that they have adequate and appropriate doses of pain medications. During an operative procedure or during surgery, it involves ensuring that there's no pain for that procedure, that they can tolerate the procedure.
Okay.
Now,
and that's before it and after?
So before, it's just a matter of assisting with pain management, providing the appropriate medications for pain. And we're part of a multidisciplinary team in that portion of the patient's experience. And so that responsibility is also taken on by surgeons and other physicians that are involved in the patient's care.
Okay.
But during the actual surgical procedure, their pain control becomes our sole responsibility. Now, what we do is there are a number of different ways that we can offer that. General anesthesia is probably the most popular and most commonly recognized by the public form of anesthesia, and this is the removal of pain completely, but also the removal of awareness. So this is what patients would normally describe as being put to sleep for surgery.
Okay. I was going to ask about that because when I think of general anesthesiology, I'm thinking, it's like I have a cut and I would just that general area. But in reality, it's completely, as you said, putting to sleep or going under, being unaware of any pain. Is that would be the correct?
That's correct. That's correct. Now, there are procedures that are done under local anesthesia. Local anesthesia is where you would get, for example, a series of injections at the site where they're operating, usually for very small procedures, and that would just cause numbness right at the site. But like I said, this is for very small, sort of simple procedures that don't require a whole lot of manipulation of the tissues, that aren't necessarily painful in and of themselves.
Okay. So, with that being said, do most surgeries need an anesthesiologist on at the table at that particular point? Would you say that most of them need that?
Yes. So most surgeries that require an operating room, they require the services of an anesthesiologist. Now, what we do for the patient will depend on one, the patient's preferences, within reason in terms of what can be performed for that particular surgical procedure. What we provide for the patient depends on the surgical procedure itself and the patient's preference within reason. So we can offer general anesthesia where they're asleep, like we just discussed. Other options include neuraxial anesthesia, which is, there are a couple of different types of anesthesia that fall under that umbrella, but epidural anesthesia is one of them, and spinal anesthesia. So these are injections in the back that cause numbness in, for example, the lower half of your body or a specific segment of the body. So you can actually be awake if you would like to for your procedure. Or you could have a little bit of light sedation or medications to help you to sleep lightly while that area that they're working on is completely without any sensation. So that's neuraxial anesthesia.
And with sorry to interrupt, with neuraxial anesthesia, is this something that the patient requests, and then you have to take a look at the procedure and say it's doable, or can a doctor say, you know what, no, we can't do that because this requires you to be completely under, or how do you tell them apart, I would say? And you know, speaking, because folks, if you're just tuning in, this is Chuck Taylor, and I'm talking with Dr. Carl Brown, anesthesiologist over at the HSA, and trying to get a kind of a broader picture of what anesthesiologists can do, won't do, and will do in a nutshell.
Right. Okay, so we offer a variety of types of anesthesia for surgeries. Now, there are a couple of factors that need to be considered when we're offering these anesthetics. For example, the type of surgery. Certain surgeries will require certain types of anesthesia, but for other surgeries, you'll have a number of different options. And as your anesthesiologist, we're obligated to discuss these options with you. So for some surgeries, you may be offered just one option. For example, it may only be appropriate to offer general anesthesia, which would be the case for many sort of extensive abdominal surgeries, for example. But for other surgeries, you may be offered options. For example, if you're having a knee replacement or a hip replacement or some sort of surgery on the foot, you can have that procedure done under either a spinal anesthetic, where we give you an injection in the back to numb both legs or the lower half of your body, or you could have a nerve block, where you get injections that numb the nerves that are responsible for the pain from the site specifically that they will be operating on, or you could have general anesthesia. And then there are other situations where one type of anesthetic may be more advisable than another, but patient preference still needs to be taken into consideration. For example, C-sections. The vast majority of our cesarean sections are done under spinal anesthesia. However, there are situations where general anesthesia is necessary because it's a safer option. And there are situations where patients are, for example, very concerned or, very adamant that they have a preference in terms of the type of anesthetic that they would like to receive. And so general anesthesia can be offered there.
And with that being said, in preparation for these types of procedures, at what stage would you meet with your anesthesiologist and say, hey, have this discussion? At what stage would we meet to talk about this?
Well, that's a good question. And the patients that meet with us for anesthesia consults fall into two broad categories. So emergency surgery is one category, and then elective or planned procedures is another category. So for emergency surgery, they often end up meeting us right before their procedure, in which case, it's a situation where something has to be done urgently. There's not been much time for planning. The surgeon has seen the patient, consented them for their surgical procedure, and then we will also consult with them and consent them for their anesthetic. So that'll happen right before the procedure, or a few hours, sometimes a day or two before the procedure, so much shorter sort of time span. For planned procedures, though, we can meet up to anywhere within 30 days of the anesthetic, of the actual anesthetic.
That's pretty broad.
Right, yeah. And the thing is, for planned procedures, because there's not as much urgency in it, patients tend to be in a much more stable condition. Their health doesn't tend to be as dynamic. And so there's a lot more flexibility. So an anesthetic visit is planned within 30 days of the surgical procedure.
Understandable. And when I meet with you, just say I'm doing, say, an elective surgery. I got 30 days. I meet with you. What types of information should come out of this meeting? What should I be able to expound to you and let you know? And I say that because a lot of people don't, I did not know that anesthesiologists had to be a doctor. I always assumed that it was an anesthesiologist. That was the limitation of it.
Right.
I hadn't really realized that it was a doctoral term that would be used.
Right.
What kind of information?
Specialty, yeah.
Yeah, it's a special. What kind of information should I disclose to you?
Okay, so when you come for your anesthetic consult, you'll be prepared to, or you'll need to be prepared to provide quite a bit of information in terms of your medical history. So this will include any medical illnesses that you may have. It will also, very importantly, and this is one that we often struggle with, if you're on any medications, it's important for you to know what medications you're on and what sort of doses you're taking. For patients that are on a lot of different medications, it would be useful, and it's often helpful to carry a list or your actual medications, because sometimes it can be hard to remember all the names of the medications, especially since they don't make them so they're easy to pronounce anymore. So that's another important aspect, or another thing that you'd be prepared to talk about. Your anesthesiologist will ask you about your surgical history and your anesthetic history more specifically. And the questions that we're going to ask are whether or not you've had any problems with anesthesia in the past, and whether or not you have any family history of anesthetic problems, because there are some sort of genetic predispositions that can lead to anesthetic complications, or make it more dangerous for certain types of anesthesia to be offered for you. Other questions that we're certainly going to ask are whether or not you have a history of recreational drug use, alcohol use, smoking, or other recreational drugs. And this information is not so much so that we can decide what sort of person you are, but so that we can plan your anesthetic. So it's a safe space for that, and it's very important that we clearly communicate exactly what we're using, or what we partake in, because it can significantly impact your anesthetic.
And with that being said, let me just dive in right here with I use the U.S. With the U.S. changing laws about recreational drug use. With that being said, a lot of states have changed their law, and you think, oh well, it's not really a drug anymore, or it's not. I'm recreational with it.
Right.
At what point should I say, you know what, this could impact what I'm doing?
If you're using any recreational drugs, then it can impact your anesthetic. And so we need to know. And once again, it's only so that we can plan your anesthetic.
Right. There's no casting of anything.
Right.
It's simply for health-related reasons.
Exactly. And as an example, marijuana is probably the most popular example of recreational drugs, especially ones that are being legalized and becoming much more popular and more frequently used, more openly.
Right.
Maybe not more frequently, but
openly. Right.
Yeah.
Correct.
Openly discussed. So marijuana or cannabis in general tends to change the way that your body processes and functions with pain. It can significantly lower your pain threshold. What this means is that you may require higher doses of pain medications, for example, when you're exposed to a surgical stimulus or when you have a surgical procedure done. There's an incision, a cut.
Okay.
These things are going to be more painful.
I wouldn't have thought of that, but because of what you're saying, would it be helpful to say if a child has, because I know they use a lot of stimulants for children with disorders and things like that to keep them calm. Suppose they needed an emergency surgery. As a parent, you should be able to give that information right away because
That's right.
that would be helpful for you to do your job.
Yes. And in that sort of situation, if, for example, if we're talking about things like stimulants for attention disorders, it's very important for us to know. Certainly, we would aim to limit how we interrupt those regimes at home. The medications that they're taking, because certainly they're on them for a reason. Once we know about them, we can sort of anticipate some of the changes but yes, it wouldn't be for us to modify their use or anything like that. But
okay,
it's good information for us to have so we can plan our anesthetic.
Yeah, and we have to remember, folks. A lot of this is THC is used for glaucoma. It's a varying things that they use for now in medical procedures and not procedures, but in medical usage. So you need to be aware of them and be able to almost expect some sort of change that's not normal that you would see in a normal non-usage person. Correct in saying that?
That's right. Yeah, that's correct.
So, sorry, go ahead.
We often see patients now, as you're saying, because it's being used for lots of medical reasons, with chronic pain presenting with prescriptions for cannabis oil, for example, or other cannabis products. And we often seek to limit or even prevent any interruption in their regime. It just means that we need to certainly plan our anesthetic accordingly to compensate or to account for the changes in the way that they process pain.
Understandable. We were talking earlier about different types of anesthesia. With that, give me a little bit more information about that, the different types and how it's broken down, because I do understand that the difference between, from a layman's term, well, I broke my foot and you're setting it and you may need to do surgery onto it to help set it, versus somewhere within my abdomen and you're doing things of that nature, or pregnancy. Give me a little bit about the different types of anesthesia that you would be looking at.
Okay, so the different types of anesthesia that are offered by your anesthesiologist range from twilight anesthesia or intravenous sedation, which is a light form of anesthesia where we give small doses and maybe even a small volume infusion of medication through an intravenous access, allowing you to sort of fall off into a comfortable sleep for them to do the procedure. You'll be able to breathe on your own. Often you're able to communicate if you were to need to communicate. You'll be able to move spontaneously. This is usually reserved for minor procedures, small procedures like colonoscopies or endoscopies, very small, like removals of like small skin lesions, that sort of thing. Just one step beyond what local anesthesia would be necessary for. So where we think you probably need a bit more than just some injections at the site to numb the area, but nothing so significant that you would actually need to be completely asleep and we'd have to take over your breathing or anything like that. So that's intravenous sedation. If we go one step further with that sort of realm where we're talking about going to sleep, we'll talk about general anesthesia like we mentioned before. With general anesthesia now, you're in a much deeper sleep. We control your breathing. So after you fall asleep, with most general anesthetics, we'll give you a breathing tube after you're asleep, of course. And we keep you asleep with gases through that breathing tube in combination with medications that we give you through the intravenous access. Now, because we have the breathing tube in, we help to control your breathing. So we decide how frequently you breathe, how deeply you breathe. And we also have to very carefully monitor your blood pressure and adjust medications accordingly to keep these parameters within normal. So we monitor many different parameters all at the same time, like oxygen levels, your breathing rate.
That's a lot for for one person to be watching. You're giving it intravenously, and yet you're monitoring it also while giving it.
That's correct. So once a patient goes into the operating room, one of the first things that you'll notice is that there's a big monitor, and you're attached to lots of different electrodes, and there are many attachments. That is all that we do in the operating room is we monitor and provide the anesthetic. So our attention is quite focused on that single patient, and that is our responsibility for the entire surgical procedure and the immediate period afterwards as well.
Okay, and when you talk about taking care of a person, it's your responsibility to put them under terminology.
Sure, that's okay. Yeah.
put them under, but also maintain them at that level of threshold without going left or right. You really maintain that very stringent that you adhere to beforehand.
That's correct. So there are three main portions of that anesthetic, and it's arguable that they're all very important. The one that people tend to be most keen to hear about is that we're gonna wake up afterwards.
Yeah, revival,
as you can imagine,
revival,
right?
of
Right,
course.
or emergence, right? So we after we induce and the patient goes off to sleep, we monitor blood pressure, heart rate, all of those different parameters, and we use that to determine, in combination with the concentrations of the medications we're given, their depth of anesthesia. We actually have a monitor that provides sort of a summarized assessment of your neurological activity as well, to tell how deeply asleep you are. And we use all of these monitors to kind of keep you within a certain range so that you're not too deeply asleep, and certainly that you're deep enough asleep so that you can tolerate the surgical procedure itself that's happening without being aware of it. And that's really important. Our patients would be very concerned about being aware.
And if you're just tuning in, this is Healthcare Today with the HSA. My name is Chuck Taylor, talking with anesthesiologist Dr. Carl Brown. We're going to take a quick break, and we'll be right back.
The Health Services Authority's new pharmacy is now open at the Smith Road Medical Center. The new location features a large, comfortable waiting area and ticketing system to improve the patient experience. All uncollected prescriptions and refill requests previously submitted will now be available for collection at the Smith Road Pharmacy. Request your refills online at hsa.ky via WhatsApp 925-6534 or call 244-2715. For more information about our pharmacy hours, visit hsa.ky.
The Cayman Islands Health Services Authority's general practice and public health clinics have relocated to Smith Road Medical Center. At the new location, you'll receive top quality care in a comfortable, modern space, enhancing your patient experience. Do you have flu-like symptoms or other non-emergent illnesses or injury? HSA's new urgent care walk-in clinic is now open at the main hospital campus. The new general practice location is for appointments only. For more information, call 949-8600 or visit HSA.ky.
HSA's cardiology clinic is now located at Smith Road Medical Center. Our cardiology team provides expert care and treatment for heart conditions such as coronary artery disease, heart failure, arrhythmias, hypertension, congenital heart diseases, among others. The new location offers state-of-the-art cardiac diagnostic testing, including echocardiograms, ECGs, and stress tests. To contact, call 949-8600. At HSA, your heart matters to us.
Now back to Healthcare Today with HSA and our host, Chuck Taylor.
And we're back, folks. Thank you for tuning in. Healthcare Today with the HSA. I'm your host, Chuck Taylor. Each and every Friday and Saturday, we get together right here and we talk about your health, all things related. From time to time, we have great guests, and I'd like to introduce once again Dr. Carl Brown. He is a local anesthesiologist right here at the HSA, and talking about basically anything related to anesthesia.
That's right.
From start to finish. And you were telling me about when you're going in for surgery and things of that nature. And I heard you give me the term revival and things like that. How is the anesthesia administered when you're getting into this? Because like doctors say, oh, you can't have, eat before you have surgery, different things like that. Tell me in preparation for it, and how is it administered into the patient and go from there?
Okay. So that does depend on the type of anesthesia that we're offering. But once again, if we go back to the one that most people tend to be immediately familiar with, general anesthesia, where you go to sleep and you're in a deep sleep for your surgery, there are two ways in which we can begin the administration of anesthesia. And one is obviously much more common than the other. So you'll find that almost all of our general anesthetics start with an intravenous access. So we'll give you an IV access, a drip, and then we give some medication through that drip once you're on the appropriate monitors, and the medication will send you off to sleep. And then once you're asleep with that medication, then we pass the breathing tube and we give you oxygen mixed with other anesthetic gases that help to keep you asleep.
Okay.
Now, for small children, where it would be very stressful, very traumatic, to give them an IV access awake, children that are a bit too young to understand. So you're talking about within an age range of maybe between, certainly between small infancy up to maybe the age of 8 or 10 years old. We offer inhalational inductions for anesthesia, where we put you to sleep with the gases, and then we give you an intravenous access.
Oh, so it's one before the other.
That's right. Right. So normally intravenous access, and then you get the gases afterwards. But if you're really young, or if you have a very severe needle phobia, because that we do see that from time to time in the public, where people are very afraid of needles, and they don't cope with that very well, despite either pre-medications to help them to relax, or just reassurance. If that is a huge problem, then inhalational induction is an option for those patients as well.
Okay.
And it works quite well. It's not quite as fast, as in you don't fall to sleep as quickly, but it's still a very effective option. And in context, for intravenous inductions, where you go off to sleep because of the drip, you're talking about in a matter of seconds.
Okay. And I was going to talk to you about that. Time-wise, we know that time is always a factor, especially with some surgeries that can be up to 5-6 hours long. Sometimes I've heard 12-hour surgery. I've heard, it happens.
24 hours.
20, right.
Even longer in very exceptional cases.
Right, exactly. The monitoring of that and keeping the person at that level. Tell me a little bit about that. How do you monitor that to make sure that they're not coming out of it, or they're not going deeper down into it? I mean, it sounds like a very fine line that you keep right there. Tell me a little bit about that.
It is a relatively fine line. So we monitor with a number of different approaches all at once. So we look at their vital signs, heart rate, blood pressure, breathing rate, if they're breathing on their own spontaneously, or if they're initiating their own breathing. And those are some of the main signs that we use to see whether or not there are any sort of discrepancies, or whether or not the depth of anesthesia is appropriate. For example, if your anesthetic level starts to lighten, or if you're not getting sufficient levels of anesthesia, your heart rate will increase, your blood pressure will increase.
Even if you're still under.
Even if you're still, this is without you even, before you're even aware, long before you reach the point where you would become aware of anything that's happening around you, still under the anesthetic. There are changes in your blood pressure, heart rate, and breathing rate, or breathing pattern. Okay. And so we monitor that carefully. And in much the opposite way, if your anesthetic depth is too profound, if the level is too high, for example, the amount of anesthesia that you're being exposed to, then your blood pressure may be too low, your heart rate may be too low, or we may find that those two they tend to go often hand in hand. And you can adjust the anesthetic accordingly to keep these vital signs within the normal sort of ranges that we would target based on your age and your medical background, or your medical history rather. So that's one way that we monitor depth of anesthesia. The other way that we can monitor it is to keep a close eye on the level of anesthesia that we're using, or the concentrations of the anesthetics that you're exposed to. So when we talk about the gases that we use to maintain your anesthesia, we have a real-time monitor of the level of gas that you're breathing in and the level that you're breathing out. And we keep those within a set range that we have enormous banks of data to support that
Right.
when you're within this range, we can expect that you should have an effective anesthetic. And then they're even more advanced or useful sort of adjuncts that we use to monitor your depth of anesthesia, like specific depth of anesthesia monitors. So we use a system called the BIS, or bispectral index, where we put a couple of electrodes on your forehead, and they measure the electrical activity in your brain and can tell us loosely what depth of anesthesia you're at or how deeply asleep you are.
Well, and that's I would think that that's a pretty sophisticated way of being able to monitor a person's vitals based on to that. Is that normal?
It is normal. It's not used. You're talking about the BIS, the
Yeah, the
bispectral
BIS, yes,
index.
the BIS,
So
sorry.
it's used. It's used for specific circumstances. So it's
Okay.
not necessary for all anesthetics, but there are situations where, for example, you'd be more concerned about awareness. For example, if the patient has a history of awareness, or if we're going to have to be very careful in terms of how much anesthetic they can tolerate for various reasons. For example, a trauma patient whose blood pressure is going to be very low because of blood loss. We certainly don't want to have them aware during the procedure, but we also know that we have to be very careful how much anesthetic we use because it's going to affect their blood pressure as well. And so when you have to walk a finer line or a tighter line in terms of your exposure or the amount of anesthesia that you provide for the patient, then this becomes more useful.
So sometimes it varies on what's going on to the patient and why they come in.
That's correct.
Because I would assume if you're having an emergency, say from an accident, this is going to be more useful.
It may be.
It may be more
particularly if the patient is unstable, because often when the patient is exposed to anesthesia, it causes a fall in blood pressure. I mean that's more or less universal. And if your blood pressure is already low for another reason, for example, blood loss from an injury, then we certainly want to give the minimum amount necessary to provide the anesthesia that you will require. And in order to do that, sometimes we have to use the BIS to help us to determine whether or not there's any risk of awareness here, whether or not this is the right amount. We have to tailor this anesthetic to each individual patient, and that sort of helps us to do that.
Okay. Do you find that people have a high tolerance for certain anesthetics? Say I'm coming in for an elective surgery, but I have a tolerance for certain medications. Do you find that you have to use more of something different to combat, to keep me at that level of unawareness versus?
Yeah, so that does vary from patient to patient. And that's part of why we get that pertinent information from the anesthetic consult in terms of medication history, because that's one of the most important sort of determinants of how you'll tolerate anesthesia. For example, if you're on chronic pain medication or you're on opioids for a long period of time, or strong painkillers, you may have a higher tolerance for anesthesia and you may require higher doses of medications. Younger people tend to have a higher tolerance in general. Children are actually exceptionally resilient and resistant to anesthesia, and so they require
Really?
Larger sort of doses and concentrations of a lot of the anesthetics relative to their size and size and weight. So yes, each patient has sort of a different response, and anesthesia is always tailored to the specific patient in front of you. But it can vary. Some people are more tolerant, and some people are less. Yeah.
And with that being said, how, if I say just elective surgery, better word for it, how would I prepare for that? Knowing that if my family or me have a higher tolerance, just preparing for the acceptance for anesthetics in general, going into something, how would I go about that? Tell me.
Well, truthfully, there's not a whole lot of difference in terms of preparation. In fact, there's none. You wouldn't prepare for it differently than somebody that we would expect to have a normal tolerance to anesthesia. What it means is every time we see a patient and we anesthetize a patient, we monitor their specific parameters and we provide the anesthetic that patient requires. So it's always going to be a tailored approach. It doesn't really matter whether you have that history, because we're gonna titrate, and we're gonna give you medication based on your specific requirements.
Okay.
And there's a common misconception. It's something that we often answer to in our anesthetic consults. How will you know whether or not it's the right amount of anesthesia? And how will you what happens if if the surgery takes long? Will that be enough anesthesia? And I guess there are two different things to explain, but in terms of how you'll know how much anesthesia you'll require, we use your weight, we use your age, and we consider the procedure itself and your medical history and your vital signs and all of the information that we're provided from our monitors to give you the appropriate amount of medication. And we in addition to that now, in terms of when a procedure lasts really long now, we're constantly providing the anesthesia, and we're constantly reassessing the effectiveness of our interventions and the effectiveness of the anesthesia to ensure that you're always getting the amount of anesthesia that you need. So it's not something that we provide in the beginning and hope for the best. That would be a very ineffective sort of approach to anesthesia. We provide it constantly throughout the procedure, and we monitor it. No, that's for general anesthesia.
Right. And with that being said, so basically, and not saying it in a bad way, but you're constantly adjusting it depending on what you see happening and also what the doctor performing it is doing. Maybe they found some other complication while doing this procedure, because I've heard in the past, someone went in for a simple surgery and they found this, and then it had to be extended because they decided that it was best to work on this now while we're here.
That's right. You,
as an anesthesiologist, redirects and adjusts for that particular time frame.
Absolutely. So if the anesthesia needs to be extended, we certainly just continue doing what we're doing. We continue to provide the anesthetics, the medications that keep you asleep, and we continue to monitor you and titrate and adjust the medications to keep you in the right sort of plane of anesthesia, so that the experience is what you expect from it. No awareness, no pain during your procedure.
Exactly. So when I'm reviving, when I'm
emerging or waking up, yes.
Emerging, yes, correct. See, folks, we're learning the correct terminology. When I'm emerging from this, what can I expect? Because sometimes I hear people in the past say, "Oh man, I came out of it and I was groggy. I came out of it," and then some people say, "I came out of it and I was fine." And then at that point, the pain medication kicked in because the anesthesiologist said, "Okay, you're going to come out in 3 hours. I'm there to combat the pain that you're going to feel." Tell me a little bit about that. Right.
Okay. So most patients will have this sort of experience. When you first wake up from the anesthetic, you're going to be very drowsy, because although a lot of the medications that we use are short acting, there's an inevitable sort of residual effect from the anesthetics. Because we want to make sure that your experience is as favorable as possible, we provide you with pain medication usually while you're still asleep, and so you should wake up with a good amount of pain control. If you do have breakthrough pain, we have additional medication ready and waiting to ensure that you're comfortable. Your comfort at that point is one of the highest priorities. So most people are drowsy. Most people are comfortable during that postoperative period of time. Dizziness and memory problems are very common. That's a very common side effect from anesthesia, and most patients experience some components, particularly the memory issues, for like about an hour or so, where you won't necessarily quite remember what's happened from minute to minute.
Dreamlike state.
Or you may, sort of a dreamlike state. You may ask a question, for example, and then forget the answer that you're given and ask the question again. And that's very, very, very common during the immediate post-anesthesia period. But like I said, it lasts for about an hour or so, after which you're more or less back to yourself. You'll find yourself probably intermittently drowsy throughout the rest of the day, once again because of the residual effects of the anesthetic, and also because of the pain medications that you'll require and that you'll be getting after your surgical procedure as well.
And I would think that that kind of goes hand in hand with the recovery stage, because your body needs to rest to recover and also build up, I guess, itself to continue on after the pain medication has subsided and continues. But would I be correct in saying that to a degree?
Well, I mean, it works out nicely that you're sleepy and that you're not moving a whole lot after you've had a surgical incision, for example, at least during the immediate period, because it does sort of reduce the amount of pain that you would experience. But we do encourage patients to be sort of up and about as quickly as possible for most surgical procedures, because there are a lot of complications that can be associated with lying in bed for a long period of time afterwards. So we tend to try and tailor our anesthetic to facilitate that happening as well.
Okay. And with that being said, we kind of alluded to some of the side effects of it. Is that what most people can expect, or are these little bit of side effects of memory loss and the sleepiness, or is there more?
Yeah, so there are other things that can be expected. Often, particularly with general anesthesia. And once again, I mean, we can talk about this for days. There are different types of anesthetics, and they do have their own sort of quirks or things that you can expect, and it does differ from case to case and form of anesthesia to the next. General anesthesia is what we're discussing now. Most people can expect what you've just said. Nausea and vomiting, unfortunately, is a very common side effect from anesthesia, and it's much better than it used to be in days gone by, because anesthesia has evolved significantly over the last half a century, very rapidly. And because we're aware of the problem, we routinely give medications to prevent it while the patient's still asleep. So you should wake up nausea-free as well. But nausea, we do see it from time to time. So nausea can be a side effect. Now, certainly, if you do experience any significant nausea, you let your healthcare providers know, your anesthesiologist or the nurses looking after you, for example, in the recovery room, because we have medication ready and waiting if you still have breakthrough nausea. So that's one other thing that can happen and is a relatively common complication, but we do take multiple steps to avoid it.
And with that being said, do nausea and maybe frequent urination, does that remove the medicine does it drop the medicine level in your body significantly?
No, not at all for nausea, because you recall that most of the medications that we're talking about are given through the intravenous route,
okay, and
breathed in through the lungs. So they're in the bloodstream. So the vomiting doesn't change the levels of those anesthetics at all. Yeah, so no, that doesn't have any impact
onto it. So it would be the constant decrease, because as you said, you want them up and moving and aware to the fullest of it. If there's any complications, it can be avoided at that point in time.
That's right. Yeah.
So that's because the reason I say that is that kind of goes along with some of the myths that they have about anesthesia. You know, a lot of people are afraid that, you know, they'll have difficulty reviving.
Right.
Right.
Yeah. A lot of people are afraid that you know we won't be able to wake them up.
Yeah.
And it's a very scary concept. And I guess movies, Hollywood, you know,
I was just going to come to that. I mean, most people have never really seen an operating room till you see an operating room.
That's right, except for on Grey's Anatomy.
Right, exactly. 90% of what we see is probably tailored for TVs and movies, and it's always over the top.
It is. It's always dramatic. There's always something terrible happening in an operating room.
and I've actually walked into a real live operating theater and was like, oh my God, this looks nothing like what I've seen in TV. Yeah. And so with that being said, what are some of the myths that we can dispel about things like this?
Well, one of them is that it could easily happen that you go to sleep for an anesthetic and not wake up. Mm-hmm. It's an exceedingly rare complication. I can tell you about my career, for example. You know, I've done thousands of anesthetics, and we categorize our patients based on risk, on how ill they are before their anesthetic. In regular healthy patients, or patients in what we call an ASA class 1 or 2, which are the healthiest patients that you can have, I've never seen a person not wake up from an anesthetic. When it happens, it's extremely rare, and there are a lot of inquiries and questions, and that's a very thoroughly investigated sort of situation because it's an extremely uncommon situation, and it's usually because of some previously unidentified health problem that they would have had. For sicker patients, now patients that have more serious illnesses, the risk may be a bit higher, and during your anesthetic consult, you will have a discussion, and if you don't, you feel free to ask your anesthesiologist about the risk of this, because each patient will have a different sort of level or category of risk. But certainly for most patients, the risk of not waking up after a general anesthetic is very, very low. You're much more likely to have something happen to you on the road, or have a more serious event elsewhere than in an operating room. It's one of the most carefully monitored and safety oriented environments to ever find yourself in.
And that's one of the things I wanted to say. A lot of times, we hear that sensational story, as you said, TV or media say, oh, so-and-so died on the operating table due to anesthesia. They didn't wake up, and these things. Most times it's due, if it does happen, it's due to misinformation, miscalculation, that they did not know this person had this disorder or whatever. Do you find that medical history needs to be really fully disclosed and looked at based off of that?
Absolutely, and that's why we have our anesthetic consult to begin with, because medical history is extremely important. For example, if you have a history of coronary artery disease and you've recently had a heart attack or you recently had a stroke, these sort of details in your history can significantly contribute. Well, first of all, they contribute to the full picture. It gives us an idea of what sort of anesthetic risk you have. It allows us to tailor your anesthesia to keep that risk as low as possible. So whatever detail you can provide about your medical history is important for your safe anesthetic.
And as we continue on, folks, thank you so much for tuning in. This is Healthcare Today with the HSA. I'm your host, Chuck Taylor, talking with Dr. Carl Brown, anesthesiologist over at the HSA. We're going to take a quick break and come right back and wrap up. Keep it right here. This is Bobo 89.1 FM.
The Health Services Authority's new pharmacy is now open at the Smith Road Medical Center. The new location features a large, comfortable waiting area and ticketing system to improve the patient experience. All uncollected prescriptions and refill requests previously submitted will now be available for collection at the Smith Road Pharmacy. Request your refills online at hsa.ky via WhatsApp 925-6534 or call 244-2715. For more information about our pharmacy hours, visit hsa.ky.
The Cayman Islands Health Services Authority's General Practice and Public Health Clinics have relocated to Smith Road Medical Center. At the new location, you'll receive top quality care in a comfortable, modern space, enhancing your patient experience. Do you have flu-like symptoms or other non-emergent illnesses or injury? HSA's new urgent care walk-in clinic is now open at the main hospital campus. The new general practice location is for appointments only. For more information, call 949-8600 or visit HSA.ky.
HSA's Cardiology Clinic is now located at Smith Road Medical Center. Our cardiology team provides expert care and treatment for heart conditions such as coronary artery disease, heart failure, arrhythmias, hypertension, congenital heart diseases, among others. The new location offers state-of-the-art cardiac diagnostic testing, including echocardiograms, ECGs, and stress tests. To contact, call 949-8600. At HSA, your heart matters to us.
Now back to Healthcare Today with HSA and our host, Chuck Taylor.
Thank you for tuning in. It's Healthcare Today with the HSA. I'm your host, Chuck Taylor, talking with anesthesiologist Dr. Carl Brown. Dr. Brown, we were talking earlier about the different types of anesthesia, and you mentioned something that I hadn't heard in a while. It was an epidural anesthesia, right, and spinal.
And spinal anesthesia.
I know some ladies are listening who are thinking about they're pregnant, and give me a little information. How how would that help versus a different type of anesthesia with pregnancy and things like that for the ladies? Or maybe someone's been in an accident and they're having some spinal cord issues and they may need to go in and do something. Tell me a little bit about that.
Okay, so for epidurals, we can offer epidurals in the operating room, but the majority of the epidurals that we offer are for the maternity ward, the labor ward, and that's for pregnant women in labor. Now, when just sort of as a quick run through, what an epidural involves is first of all cleaning the back, giving a small, tiny injection with some numbing medication to numb the skin. So after that, there's not a whole lot of pain. And then we pass a needle through the area that's numb, and it goes into the spine, and we pass a very thin catheter through that needle, and the needle is removed. So the catheter stays in the back. Now, this catheter remains in a place where it's very close to the nerves that are responsible for the pain that you would experience during labor. And we inject local anesthetic as an infusion through that tubing to bathe those nerves, and it reduces the amount of pain that you experience. Now, when a labor epidural works the way we intend it to, which is the vast majority of the time, it is the gold standard for pain control. Mm-hmm. There have been many different sort of pain strategies for labor, but none of them quite compare or come close to the pain relief that you can have from a labor epidural.
Okay. Now,
there are a few misconceptions around the epidural. One of them is very common in the public to discuss the risk of lower back pain. You know, a lot of people will say, for example, especially around the time of labor and delivery, that I had an epidural, but my back was never the same afterwards, and I've had back pain ever since. And the truth of the matter is that labor epidurals or epidural anesthesia in general is not normally associated with chronic lower back pain. But one of the problems with chronic lower back pain is that it has many different causes, and it's also very common, and it's particularly very common during the period of labor and delivery for reasons separate and apart from epidural. So most patients, when they're fully investigated, will find that there are other causes for that back pain that aren't related to the epidural itself. Mm-hmm. So that's one of the misconceptions around epidurals. One of the other misconceptions, or one of the other fears, and it's understandable because this is a needle that goes into the back, is that you could have damage to the spinal cord, permanent nerve injury, paralysis. Mm-hmm. Now, that risk exists. To be clear, that risk exists, but it's extremely rare. And when I say extremely rare, we're talking about 1 in 750,000. We're approaching 1 in a million sort of chances of something like this happening. Right. So it's a very rare complication. It's so rare that there are only case reports of this happening, which means that we can't get enough of these patients together to have discussions about how they happen, because there's just not enough cases of this happening worldwide. Rare. It's an extremely rare complication. And it's rare for a number of different reasons, but one of those reasons is because we thoroughly explore the history of each patient that we offer an epidural for, and we ensure that there are no risk factors for these complications happening. So we offer it in the safest sort of environment possible, with the safest technique possible. Mm-hmm. And all of these strategies have come together to make it a very, very safe procedure.
Understandable.
Now, spinal anesthesia, in a very similar way, the risk is very low of complications like lower back pain or permanent damage to the spinal cord. So it's a very safe option for certain surgical procedures, and something that we can readily offer and happily discuss with our patients as an option for anesthesia.
And I think that's one of the things I'd like the listening public to understand, that you need to have a very honest and frank discussion with your anesthesiologist. And the reason being is because they have thousands upon thousands of times they have done this. So you need to be aware of what you're asking for and what you're doing. I would think, based on our conversation today, because most people may not think of an epidural as helpful. They may, I had 5 family members and they would all complain, but once again, it may be for a different reason and understanding. So you need to be very frank and be aware of all of the factors of it so that you can have a very frank and really honest discussion with your anesthesiologist, because they control your pain. You guys, that's what you do. That's all that you do is pain management at a time of crisis, which I think is very important. So with that being said, is there anything else that you want to let people know regarding anesthesia before we get on out of here, Dr. Carl?
Well, not a whole lot more. I just want to say that at the Cayman Islands Hospital, our anesthesiologists, we wear a couple of different hats. We've talked about our anesthesia services that we provide in the operating room.
Mm-hmm.
We also provide, like we said, a labor service, a labor analgesia service with epidurals, and that's a 24-hour service as well. And we're all dual trained in our department, so we provide critical care services as well. So we're anesthesiologists, but we also service the critical care unit and provide sort of life support services for patients in that department as well.
All right. Thank you so much, Dr. Carl Brown, for stopping by here today and talking to us about the very important part of anesthesia and anesthesiologist, what you do. Thank you so much
for having me. Thank you.
My pleasure. My pleasure. You've tuned in to Healthcare Today with the HSA. I'm your host, Chuck Taylor. Keep listening. We will be back with exciting talks about your health and all the wonderful things our friends over there at the HSA are doing. Keep it right here. This is Bobo 89.1 FM.
The Health Services Authority's new pharmacy is now open at the Smith Road Medical Center. The new location features a large, comfortable waiting area and ticketing system to improve the patient experience. All uncollected prescriptions and refill requests previously submitted will now be available for collection at the Smith Road Pharmacy. Request your refills online at hsa.ky via WhatsApp 925-6534 or call 244-2715. For more information about our pharmacy hours, visit hsa.ky.
The Cayman Islands Health Services Authority's general practice and public health clinics have relocated to Smith Road Medical Center. At the new location, you'll receive top quality care in a comfortable, modern space, enhancing your patient experience. Do you have flu-like symptoms or other non-emergent illnesses or injury? HSA's new urgent care walk-in clinic is now open at the main hospital campus. The new general practice location is for appointments only. For more information, call 949-8600 or visit HSA.ky.
HSA's cardiology clinic is now located at Smith Road Medical Center. Our cardiology team provides expert care and treatment for heart conditions such as coronary artery disease, heart failure, arrhythmias, hypertension, congenital heart diseases, among others. The new location offers state-of-the-art cardiac diagnostic testing, including echocardiograms, ECGs, and stress tests. To contact, call 949-8600. At HSA, your heart matters to us.